Greetings. I'm Bruce Oviagle, the president of the Society for Equity Neuroscience, and I'm happy to welcome you to another episode of Disparities Dialogue. This month, we'll be focusing on Parkinson's disease. I'm delighted to introduce an expert panel of movement disorder specialists who are willing to share their expertise and their experience with us as we go through these very pertinent articles. So this is our group of expert discussants. First, we have Dr. Sana Aslam, who is faculty at the University of Colorado. We also have Dr. Bayram, who is also faculty at the University of Colorado. Dr. Paulina Latapi is an assistant professor at Northwestern University. And last but certainly not the least is Dr. Karlo Lizarraga, who's an associate professor of neurology at the University of Rochester. Welcome, everyone. So we'll start off by a quick glimpse of the different articles we hope to discuss today. So the first article pertains to linking patient characteristics, social drivers of health, and geographic location on access to device-aided therapies among patients who have advanced Parkinson's disease. The next article takes a look at the link between early onset Parkinson's disease and its impact on regional and national burden in over 200 countries and regions over a 3-decade span. Our third article looks at contributors to gender disparities in Parkinson's disease caregiving. Our fourth article looks at the important issue of representational disparities in enrollment of Parkinson's disease clinical trials. Our fifth article looks at the mechanisms underplaying inequitable access to Parkinson's disease care, and it's a critical interpretive synthesis. Our sixth article goes over the issue of advanced care planning in Hispanic populations with Parkinson's disease. Our seventh article takes a look at ethnic and gender disparities in access to deep brain stimulation surgery for Parkinson's disease. And our final article takes a look at the important issue of gender differences in depression, anxiety, and quality of life in Parkinson's disease before and after deep brain stimulation surgery. So let's get into our articles. So the very first article published earlier this year in Parkinsonism and Related Disorders takes a look at patient characteristics, social drivers of health, and geographic location on access to device-aided therapies among Medicare beneficiaries who have advanced Parkinson's disease. And Dr. Aslam is going to kindly walk us through this one.
So this article was published just a few months ago, and specifically looking at Medicare beneficiaries and device-aided therapies. For the purpose of this article, or for the study, they defined device-aided therapies as deep brain stimulation, so surgical interventions, but then also enteral, carbidopa, levodopa. They did a very interesting, so they looked at 2018 to 2020, so a 2-year span, and they came up with proxy criteria for advanced Parkinson's disease. So this is a little different than much of the prior literature, which looks at all comers when they look at Medicare data is for just the diagnosis of Parkinson's disease. But here they really wanted to characterize a specific cohort that would be eligible for device-aided therapies and then really investigate how many of those people are getting these interventions and what are the differences between those groups. So their criteria was based on ICD codes, total daily levodopa equivalent dosing. So they looked at medications and calculated it to a standardized levodopa dosing parameter. They looked at the use of rescue medications. Inhaled levodopa, for example, that's often used in more advanced disease. And then they also looked at the use of medications that are used to treat dyskinesia, like amantadine, so another marker for advanced disease. So they came up with this criteria, this algorithm that they could implement within the Medicare data set and linking it with medication data as well. And they came up with a list of about 500,000, about 500,000 Medicare beneficiaries, or they looked at about 500 Medicare beneficiaries, and about 22% of them met proxy criteria for APT, which is advanced Parkinson's disease. I should also note they made a really nice regional map of
Mm.
just the prevalence of Parkinson's disease, of all comers, and then also just by how many within each state had advanced Parkinson's disease. And then they also looked at so one was the device-aided therapies, but then they also looked at things like how many facilities in the state are prescribing or providing these advanced therapies. So they looked at the NPI of surgical intervention of the folks doing the surgical intervention, so DBS, and then also some of these. This was 2018 to 2020, so the enteral infusion was Duopa. The newer one was not yet available for the purpose of this. And so they found that only 2% of the Medicare beneficiaries that met criteria for advanced Parkinson's disease were receiving device-aided therapies. And 76% of those were DBS primarily. And then those who were older, 75 years and above, female, identifying as Black, and then having a moderate to severe comorbidity burden. So they look at the Charlson Comorbidity Index. And then lower household income. These were associated with a lower likelihood of receiving device-aided therapies. Younger patients are about 2 to 3 times more likely to actually receive these interventions. And then what was really interesting, at least to me, was the distance that patients had to travel for these interventions. The average was about 100 miles, though it ranged anywhere from 11 to 255 miles. So definitely a lot of regional variation in that. And then, of course, as expected, on the East Coast, there were a lot more facilities compared to much of the middle of the country. And so there's a lot of differences there. Some of the limitations of the study are, of course, this claim-based, sort of these proxy definitions. There's no validated sort of standardized definition for advanced Parkinson's disease. So it was a pretty clever and interesting way of operationalizing a definition, but not necessarily validated. And I think one of the bigger limitations is the medication equivalent. So medication is very much higher burden of medication and more advanced disease. However, most folks who treat people with Parkinson's disease know that these medication regimens can be quite complicated. And so what is prescribed may not necessarily reflect what patients are actually taking. And so the accuracy of the actual regimen in the daily levodopa equivalent dosing, there wasn't a good way to verify the accuracy of that calculation. So really the biggest sort of conclusion was that there's a large proportion of advanced Parkinson's disease that qualify for these therapies or may qualify for these therapies, but they're not getting those therapies. And there are significant differences based on social demographic and sort of geographic factors that is affecting their access to these interventions.
No, thank you, Sana. Very interesting study. I don't know if any of our
Mhm.
other expert discussants have any other comments on it. Looks like not. Sana, you already described the limitation of this claims-based proxy definition and how it might misclassify things. So that I think is clear. But to what extent do you think the observed disparities in age, in sex, in race, and income might reflect patient preference versus structural barriers versus provider referral patterns?
Yeah, that's really interesting because with Parkinson's disease, we know there are disparities in being diagnosed, disparities in actually getting to see a physician, disparities in actually being prescribed an appropriate amount of medication or ancillary services. So, I mean, there's cutoffs at each stage of the journey with this disease, and those may be hard to quantify. And then there are other studies that have looked at particularly men versus women in terms of actually undergoing these interventions. And so there may not be a difference in who is offered these interventions and who chooses to actually undergo them, whether that's risk aversion or um, mistrust of healthcare or financial reasons. And so those things may not be captured in such a large database.
Hmm, that's interesting. And I'm sure we'll see this as we talk about some of the other articles as well. This issue of access, given the very low device-aided therapy utilization rate of about 2%. To your mind, what changes, whether it's clinical, referral system level, could meaningfully improve access?
There's been a fair amount of data specific or analyses of DBS, particularly in disparities, and they've persisted over time. And as you said, it's such a low utilization in the grander scheme of things. I think really looking at it a bit more upstream is where we need to focus our interventions, investigating, like we said, who is actually getting the opportunity to receive these devices or advanced therapies. And then after that, who's actually undergoing them? And so where in that pipeline are we losing people? I imagine every step, but I think really just honing in on each level will give us a bit more information on really driving interventions.
Fascinating. All right. Our next article, published again in Parkinsonism and Related Disorders earlier this year, looks at the issue of early onset Parkinson's disease, and this time looks at burden, whether it's regional or national, in over 200 countries or regions over a 3-decade period. And Dr. Aslami again is going to kindly walk us through this one.
Yeah, so this is quite different than the last one. So we're looking at early onset Parkinson's disease, and defined as those with onset prior to the age of 40, and looking over about 30 years of data globally. So a much larger data set, much more heterogeneous data set, and we'll circle back to that. And they looked at, so this is the Global Burden of Disease study, and that collects data from lots of different resources. So it's not directly collecting data on its own, but just compiling other publicly available or accessible data. And so early onset Parkinson's disease is about 5 to 10% of all Parkinson's disease. And it's given the younger age and sort of a longer lifespan with the disease, there's more disability associated and more socioeconomic implications. And so this study looked at about 200, a little over 200 countries to really investigate the incidence, mortality, disability adjusted life years, and predict sort of trends up until 2035 for early onset Parkinson's disease. And then they looked at differences based on sociodemographic indices, which is a measure of social progress and healthcare burden for different countries, and there are different metrics that compile this or create this composite score. And mostly what they found is that the global incidence of early onset Parkinson's disease is increasing, and it has increased over this 30-year span that they looked at, particularly in the late 30s cohorts of 35 to 39. Males were consistently had a higher burden of disease than females in this group. Higher SDI regions showed greater burden of the disease, and so that actually was presumably more associated with better detection and diagnosis of the disease. And then lower SDI regions showed an increasing trend, but presume underdiagnosis within those regions as well. And there was considerable regional variation. And this is a really nice article that talks about lots of different regions, so globally lots of different regions. And so we probably don't have time to talk about each area, but they do a pretty nice job of characterizing and demonstrating the differences by country and region. And so the limitations, as we talked about, this is, again, large data set. This is compiled from lots of different data sets. And so it's only as good as the diagnosis and only as good as the reporting. And so early onset Parkinson's disease is, difficult to diagnose even in countries where genetic testing is more readily available and increasingly available, let alone countries that have very limited healthcare resources and even access to neurologists. We all know that there's a shortage of neurologists within the US, but also significantly so around the country and in many countries. So, and then the metric that they use, the sociodemographic index, may not capture other things like environmental aspects, pollution, occupational exposures, lifestyle factors that may impact the incidence of this disease and manifestation of the disease. And so There's, it's a really nice way to at least get some baseline data of what the global burden of early onset Parkinson's disease is. There is expected or not surprising geographic and socioeconomic disparities. And but there are limitations to that large, as with all large data sets and interpreting it. But there's nothing out there yet, so this is a nice start at least.
No, and it's a great point. I mean, we all are aware of the global burden of disease data
Mhm.
sets, but like you said, it comes with many, many caveats, but it's arguably the best thing we have out there. I don't know if
Yeah.
any of our other expert discussants have any other comments to make on this paper.
I also want to add when we're talking about the burden of the disease, it's typically not just the person living with the disease that, gets burdened by the disease. And I think we fail to sometimes include that aspect in, these databases, these work, especially in a disease like Parkinson's disease. You can't disregard the caregiving burden that comes along with, someone being diagnosed younger in the game and
Mhm.
having to need that care for a way longer time.
Such a great point, Dr. Bayram. I
Yeah.
completely agree. And hopefully, in some way, future studies or smaller studies will be able to capture that burden. Yeah, it's a great point. Any other perspectives on this from the other expected discussants?
I
Sana,
want
I
to
just
make
want to
a quick
go ahead,
point.
please. Yeah, Karlo, of course.
I like the conclusion, right? That health systems should prioritize earlier diagnosis and expand access in low SDI regions. I think that that is a very important point, and I don't think so. This study comes from a group, I assume, that has some global representation, but a lot of the research looking at global burden is done by institutions or researchers that are in high income countries. And so the true, providers and populations that are being affected by this, they're not really that involved. They may not even be aware of what is coming. And so it's kind of our responsibility as, being part of this higher or, high income countries to kind of bring this awareness and help them prepare. There have been a couple of pieces in our journal, in the Equity Neuroscience Journal, about specifically trying to address that gap. So yeah.
So well said. So well said, Karlo. Thank you. I agree.
Yeah, I
Go ahead,
I'm
Sana.
sorry, I was just going to say, I think that's such a great point, Carlo, about the dissemination of information. Because especially for this, I mean, the projected, we didn't spend as much time talking about their projections, but I mean, mortality projections were quite high, especially for that late 30s group. And so there's clearly a need to intervene sooner or to, at least some awareness about it.
I agree. I agree. And if I may just to ask one question of you, Sana.
Mhm.
Um, so of course I know that these are estimates and everything, but in your own practice and of course your expert knowledge of the literature, do these accord with potentially true increases in disease, do you think, whether it's in the US or in other high income countries, or do you just think this is better detection and coding and survival again? I know there's no right answer. What are your thoughts?
Yeah. I really do think that it is a detection issue. I mean, some may argue that there are environmental exposures and increasing exposures and pollution, and we're finding more and more associations with a changing sort of global climate that may be affecting sort of the incidence or manifestation of these neurodegenerative diseases. But I don't think we can ignore the awareness and the diagnostic sort of aspect of it.
Yep. Thank you. We'll move on to our next article, and this one was published in the Journal of Geriatric Psychiatry and Neurology in September this year, and looks at the issue that Dr. Bayram, who is going to kindly discuss this, raised earlier, the contributors to gender disparities in Parkinson's disease caregiving. Eche, do you want to kindly walk us through this one?
Yeah, so this was a great paper covering the burden associated with caregiving and how it differs by gender. And, we have to start off by just acknowledging that informal caregivers do take majority of the burden when it comes to Parkinson's disease care, and that is the caregiving that is provided without getting paid for it. So, our families, spouses, most of the time kind of take on that load when someone's dealing with a chronic disease like Parkinson's. But so far, we know that women with Parkinson's disease are less likely to have informal caregiving than males. Men, they still get a lot of informal caregiving, but compared to the men, they are more likely to actually get paid help. And they can experience disparities more because of this difference in informal and formal caregiving. Because, the quality, the type of relationship really impacts the person's Parkinson's experience, and we see this difference for women and men. And in this study, they used a caregiver survey to see about, how things are looking from the caregiver's perspective through the Parkinson's Foundation Parkinson's Outcomes Project, which includes mostly North American sites that are Parkinson's Foundation Centers of Excellence for Parkinson's disease. So it's, top of the top sites that provide excellent Parkinson's care. And they sent a survey through this project. So not everyone, did the survey, keep that in mind, but it's a pretty cool project that is collecting, systematically collecting clinical data through these patients that receive care at the Parkinson's Foundation centers. And based on the people who responded to the survey, they saw that most caregivers are spouses, and being married or not being married does contribute to the gender difference for having a caregiver. So women were less likely to be married, more likely to be widowed. So they were less likely to have a caregiver because they didn't have a spouse. And women caregivers were caring for people with Parkinson's disease who had more disability and worse cognition. So they required more care. And women, compared to the men caregivers, were spending more time doing house chores, and men caregivers were spending more time helping with mobility for their loved ones. And compared to the men caregivers, women caregivers experienced more strain and they had less time for family. But despite experiencing more strain and saying they have less time for family, they still reported similar access to help, similar levels of depression, and similar feel of preparedness. So, that can kind of point to women being less likely to complain despite having more burden. And it showed in that survey too. And, with any big study, there were some limitations. They only looked at binary gender, and most of the spouses were of opposite sex. So they probably captured mostly heterosexual couples. It was a Parkinson's Foundation Center of Excellence cohort, which I mean is like the top of the top kind of care. So these people already had access to excellent care. So it's not a great, representation of the community living with Parkinson's, who are less likely to have support. And we see, especially in certain groups that are from the lower socioeconomic class, they are less likely to have informal caregiving from their loved ones because their loved ones have to work and, make funds. And the majority of this cohort had good access to things. They had good socioeconomic levels. Most were non-Hispanic white. They had at least some college education, which means a lot, which, really shows they had a good socioeconomic standing, and they were saying they can at least make ends meet financially, so they don't need to worry about that beyond their disease. And, they were on the younger side with a mild disease for the most part, so the caregiving didn't necessarily require a lot of dependency care. And, what they found in conclusion was spouses are the main caregivers when it comes to Parkinson's disease. And based on, the caregiver gender, the needs may look different, even if they have similar access. They're just may experience things differently. So, when we're trying to address the needs for people living with Parkinson's disease and caregivers, we do need to take into account not just the person with Parkinson's disease, their gender, but also the caregiver gender too, because that's going to impact what they are going to complain of, what they're going to need.
Oh, that's great. Interesting. I wonder if any of our other expert discussants have any other comments on this particular paper. Dr. Aslam?
Oh, I was just curious about, I mean, this is hard to answer, but do we expect that some of these trends will change in the next 10 to 20, just with different, presumably changing social norms and traditional gender roles? Do we expect that these, sort of this data will maybe, hopefully be outdated?
I think so. I mean, even if you look at different groups, this information is going to look very different because gender norms look very different across different ethnic groups, different age groups, and different countries. Some cultures really come heavy with women have to be the caregivers, and some cultures you don't see that imbalance as much. So even now, I think, we can't really generalize these findings to all of the population with Parkinson's.
Yeah, and that's an important caveat which you had mentioned earlier, this issue of, again, whenever one does research, it's the issue of generalizability. And as you mentioned, Eche, this is the top of the top. And so very important in terms of direction and insights, but may not necessarily extrapolate to marginalized populations necessarily. And it would be wonderful to have some further insights as to how informal caregiving might look in these different cultures and for different genders as well. Other thoughts?
I want to add, even though, there are those limitations that comes with data, I think it's a big thing to show, even with this community that has good access, there are still gender disparities. So imagine how things are for people without access. They may be less, they're probably more. So, these are things we really need to think about addressing for people to have better quality of life.
Dr. Latapi?
I was going to say also consider that the caregiving needs might change as the disease progresses.
Right.
So that would be also interesting to see how that plays out. Yeah.
Absolutely. Thank you. All right, we'll move on. Our next paper looks at the issue of representational disparities in enrollment of Parkinson's disease clinical trials, was published as a research letter in Movement Disorders earlier this year. And Dr. Bayram is going to kindly walk us through this one.
So this was a lovely letter from Psy and colleagues, and they looked into whether, we have good representation in Parkinson's disease clinical trials. And we know Parkinson's disease doesn't really discriminate. It affects everyone. And we know it affects diverse populations. And, what you're trying to get clinical trial data on has to represent those people that are getting affected. So when we offer someone a treatment, we'll know what the outcomes are likely going to be. So they looked, if that's the case, they assess sex, racial, and ethnic representation using clinicaltrials.gov registered randomized interventional Parkinson's disease trials, which represents a huge chunk of Parkinson's disease trials, but not all. And they compared that, representation to the global burden of disease population for people with Parkinson's that Sana explained before. They found 328 trials. They saw that around 40% were females in those trials, which does represent the Parkinson's population. It is similar rates. And for ethnicity and race, they didn't find a lot of data in trials that were conducted outside of the US. It looked like the US trials are, reporting ethnicity and race info a lot more. And they actually didn't find, rates from global burden of disease population either. So they compared it to the US population in general. So it's not really, representative of the whole world's Parkinson's population. And they did find, in these US conducted trials, majority, a very high majority were white. And it does not correlate well with the US population, and it probably doesn't correlate well with the US Parkinson's disease population either. And, we know that females, these underrepresented racial and ethnic groups, they experience disparities for diagnostics and access as is. So they're not even represented in the general Parkinson's population. And on top of that, even the people that get represented in Parkinson's population don't make it into the clinical trials as much. And also, a big important part is they noted trials don't really include the adequate categories either. A lot of the trials conducted outside of US, they didn't report race, ethnicity, which will come in handy a lot. We think of different countries, and each country doesn't completely correspond to a whole ethnic or racial groups, and we're kind of missing those. And unless you're from that country, you may not even know the makeup of the ethnicity race in those countries. For instance, I'm Turkish, and Turkish make up maybe 75% of the population in Turkey, which is not common knowledge. So if I'm, reporting a trial from Turkey and I'm not sharing any race ethnicity data with you, then you're not going to know that my population was representative or not. So, we have to be mindful of proper reporting. Sex and gender are not the same thing. Sex is the biological category, gender is the social category. So we have to be mindful of those things because they're going to change how we understand the data and how we can apply the data. So, there's nothing wrong with including non-Hispanic white populations in the clinical trials, but we have to be mindful of including, Black communities, American Indian, Alaskan Native communities, Native Hawaiian, other Pacific Islander, Hispanic, and also other ethnicity and races that may not get represented in the US. We have to get information on all of those people so we can have, more applicable findings. And we also need to improve these, representations, not just for therapeutics, but also for diagnostics, because they're gonna, feed into one another. We have levodopa response as one of the criteria in our Parkinson's disease diagnostic criteria right now. And, a lot of the studies on levodopa came from a certain group of people. So maybe, a certain ethnic racial group is not as responsive to levodopa. And because of that, we're not diagnosing them properly because we say, hey, you didn't show us the response we expected. So you probably have something atypical. And then we're, calling them wrongly. So we have to be mindful of that. Socioeconomic classes, they don't get represented as well, and they don't access clinical trials as well. And our findings are going to get limited if we don't include everyone.
Oh, so well said. Any other comments from our other expert discussants? Dr. Aslam, Dr. Latapi after that?
Yeah, just a quick thought. In terms of reporting race and ethnicity, I think that was only mandated just a few years ago. Was it like 2017 or so within the US? And so up until then, reporting was poor because I know I've tried to look back at, older data for some of these, scales that we use, and it's just not reported. One could guess what it was. But I think just to the point of like sometimes things need to be mandated to get institutions and groups to really just to shift that needle and like even to do the bare minimum.
Yeah, absolutely. Dr. Latapi?
Yeah, I mean, along the same veins, I think this is a great letter to have because while we know we know that this is an issue, it's good to have the numbers as well to support that thought. And also to try to, go to the next step, right? How can we improve on this? And it really starts, I think, from the time that the clinical trial is being designed. We need to think and have a certain goal of put that as a goal to have a diverse enrollment. Otherwise, I don't think that unfortunately we're going to see a lot of change in these numbers over the years.
And that's a great point because I think actually you made a very good case for why we need trials to collect data on sex, gender, ethnicity, and race variables. You made that case abundantly clear, and so I hope researchers and policymakers are listening or watching. But again, to Paulina's point, the issue is how do we move forward? And Sana, of course, has mentioned the issue of trying to, in many ways, have agencies mandate such reporting, funding agencies mandate such reporting. Are there any other ways that we can potentially improve inclusivity in clinical trials to address this issue of underrepresentation?
I think the study design, as Paulina mentioned, is absolutely important. We are, sometimes including people only with caregivers. And we just saw not everyone has a caregiver, and especially the minoritized groups are less likely to have caregivers that can show up for clinical trials when we're just recruiting for in-person trials at, these more top of the top type of centers. Many people don't have access, and unfortunately, a lot of people without access may be from those minoritized groups too. So we're excluding them as is. We see certain comorbidities more prevalent in certain racial and ethnic groups, and we, exclude without a basis with those comorbidities, then we're just getting rid of those ethnic and racial groups too. So we kind of have to be mindful of that when we're trying to design our studies. And we see, when you're trying to recruit for studies too, we have to overcome centuries long of mistrust and abuse in these minoritized groups. And, they've already been abused by so many clinical trials, so many research, and you can't just go in there and expect them to show up and sign up. You do have to build community. You do have to build relationships. It takes time. It takes a lot of investments, but, we're going to overcome that all together. So we do need to go into the communities, show that we're interested, show that we want them included, but give them time to actually build trust without just showing up, giving a sign out sheet, and then expecting them to sign up in all our studies. You have to invest sometimes without expecting a return for those relationships to grow over time.
Yep, very well said. An important issue and a great discussion. Thank you. We'll move to our fifth article, and this is a systematic review. It looks at the issue of mechanisms of inequitable access to Parkinson's disease care. And Dr. Latapi is going to kindly walk us through this one.
Yeah, so this is an article by Cohen and colleagues. So again, I think we already know that Parkinson's disease is a complex condition, not only involving motor symptoms, but also non-motor symptoms. And recently, the care model has really shifted towards a multidisciplinary model. We have already discussed the rising prevalence globally. And we know that the access to diagnosis, to treatment, is challenging, especially in minoritized populations. So what the authors did was use this critical interpretive synthesis, which is a little bit different than that we usually see in a summary review article, where with this CIS system, what the authors do is ask, really look at the articles included and ask how people have been thinking about the specific problem, in this case, the lack of access to certain treatments and care models. And then looking for patterns in assumptions, how we define different problems, how we define access to care, and then going one step further and proposing some possible new framework to try to address this issue. So in this specific study, the authors included 96 studies. They looked at the 5 major databases, and they used both qualitative and quantitative studies. And so after conducting their analysis, the authors found 3 mechanisms that lead to this inequitable access, and these mechanisms feed into each other. The first one was geographic context, so people in rural areas have less access to specialists. There's fewer services, especially those adjunctive services that form part of the care team, such as occupational therapist, speech therapist, physical therapist, mental health care as well. There's also the provider assessment, so those biases that come with the providers, whether it be neurologists, primary care physicians, or other healthcare staff who see the person, and then there might be some bias as far as making the diagnosis. So again, perhaps people from certain races, from certain ethnicities, from central sex might be less likely to receive a diagnosis of Parkinson's disease, so there's a delay in diagnosis. And also as far as referral patterns, who is referred for certain treatments, like advanced treatments, like deep brain stimulation, for example. And so that's another important component of this access to care. And then the last one is that intersection into this social marginalization. So how different barriers will interact and intersect, and they are they compound the disadvantages for a lot of these populations. So we can imagine if populations, people who live in a rural area who are part or identify in certain racial or ethnic groups, and who perhaps are also women, they might have then all of those factors compound into this lack of access to care and support systems. Of course, there are some limitations, as with any article, any research that's conducted. Most or all of the resources were in the English language, so we are not truly capturing perhaps other factors that may be playing a role in countries where English is not the main language, or not the main language that's used to publish. Also, because of this, most of the studies are heavily weighted towards US-based studies. And most of the studies were quantitative, meaning that less lived experience, such as interviews, for example. And of course, along the same veins, less evidence from lower and middle income countries. So what we see here is that really there's different mechanisms through which patient populations have less access to care, less access to interventions. And when we're thinking of how we're going to try to help with these barriers, we really have to think on multi-level interventions. So it's not enough just to focus on race, not enough just to focus on gender or geographic disparities. We really have to think, take a step back, look at the big picture, and look at all of these multi-level access barriers to access. And so this article proposes a model that we can use as we develop perhaps newer interventions, newer programs to try to help with these barriers.
Fascinating. Thank you, Paulina. Do any of our other expert discussants have comments on this one?
And I just wanted to add, since they mentioned the, fewer specialists, limited services aspect, a lot of the countries don't have the specialized training to work on these specific types of diseases. And a lot of people from low and middle income countries rely on publications or guidelines coming out of countries like US, where there's more specialty training, more access to things. So I think some of work falls amongst all of us too, where we have to be very careful about the outputs we're putting out there, because that is going to get used by those specialists who may necessarily not have a ton of access to information, a ton of awareness about these diseases too. So we do have to be mindful of, whenever we're writing our papers, we're putting research publications out there, that we have to cater to them as well.
It's a great point. And before I know Sana has a comment or a question as well, is how do we, because again, Paulina pointed out that this was mostly English-based, mostly US. You've just pointed out the issue, Eche, of other low to middle income countries tend to use these guidelines and these recommendations. How do we get more contextually appropriate guidelines? Because again, sometimes the context is different. And can we just extrapolate from one to another, just like the other article you spoke about, how we need more representation, because what might apply to one group might not apply to other. Any thoughts about this, any of you?
Yeah, I mean, I think that's where we really need to engage more in global partnerships, right? I think we are relatively good at engaging within the US system, and our foundations are also good. I mean, we just presented this article based on Parkinson's Foundation Center of Excellence data, but I think also there's the potential to engage on a global scale, and that's something that the movement disorders society is moving towards. But I think that's where really connecting with those people who are seeing patients with Parkinson's disease in different countries, who are conducting very interesting research, but also just fostering those global partnerships will be very important.
Yeah, I think I was going to say the same thing, is that, and I think it circles back to several of the points we've made. I mean, including clinical trials and just involving and representing people that are affected by these, whether it's at the, clinician level or patient level or both. And, do we need to, one rule is not going to apply to everyone, but the other point that I was going to make is that it's really nice to see the intersectionality of these different vulnerabilities, because it's not just one thing. And so have a metric that kind of, takes different aspects and defining the highest risk population and the lowest risk and based on different metrics is, I think, really helpful, and maybe makes it a little bit more generalizable.
Agreed. Any
One
other
more
thoughts?
point.
Yes, please.
Yeah,
Karlo.
I think something else we could do is to also review their literature. And they publish also. They write books, they write papers. It may not be in English, but with advances in translation and we could easily incorporate their research and their literature into global guidelines, right?
No, absolutely. And that's a fair point. And I wonder if this could be done again using AI to try and translate all of those things and making this a truly global CIS, so to speak. But no, that's a great point. Thank you.
Yeah, I was
All
going to
right.
say we're
Yes.
piloting an AI for clinical notes that will interpret a language and convert it into notes. So it's doable.
It's coming. Nice. All right. Great. Thank you. Our sixth article, published in Clinical Parkinsonism and Related Disorders, looks at the issue of advanced care planning in Hispanic populations with Parkinson's disease. Dr. Latapi is going to share her thoughts about this one.
Yeah. So again, this Peabody and colleagues focused on advanced care planning. There's been several studies that show that advanced care planning is part of this care component in people with Parkinson's disease. And in this particular study, they focused on Hispanic populations where that has not been reviewed in Parkinson's disease populations. There's some data on in cancer patients and general populations. And so the aim was to investigate whether there's any disparities in this advanced care planning knowledge, what are patient populations, and also as far as having these documents completed, and whether there's any difference between Hispanic and non-Hispanic people with Parkinson's disease. So this was a cross-sectional survey of 250 participants, and this included people with Parkinson's disease and their care partners. This was conducted at the University of Miami, which has large Hispanic population as part of their movement disorders clinic. The survey was available in English and in Spanish, and then they conducted some statistical analysis to compare answers between Hispanic and non-Hispanic groups. So as far as those documents that had been completed, so we're comparing Hispanic and non-Hispanic populations. We see that the majority of non-Hispanic population had completed an advanced care planning document, which was mainly a health care proxy. And so that's 66 or 67% of non-Hispanics compared to 20% of Hispanics. And as far as advanced directives, the trend was also similar in that only 6% of Hispanic population had completed a document in comparison to 30% of non-Hispanics. The people belonging to or identifying as Hispanic were also more likely to report to never having heard of what an advanced care planning document would entail. So some lack of knowledge there. And when looking at their preferences, a majority of people belonging to the Hispanic group would like to discuss these possibilities, these documents, and they would most of them prefer to discuss them with their neurologists, but they would also like to discuss to have these discussions later in the disease course, which was different from the non-Hispanic group, who would prefer to have this discussion earlier. And actually, a majority of them responded they would like to have those discussions when they were not yet sick in the non-Hispanic group. But in general, both groups consider these discussions important. Now, some of the limitations of this study was that as far as Hispanic population, we know that when we use the term Hispanic, that actually encompasses a wide variety of groups. So in this case, most of the people who completed the surveys were Cuban American. So again, we cannot really account for any cultural differences that might come from people who belong to different Hispanic subgroups who have belong to different Latin American countries. And the study did not account for the length of time that people had been in the US. So sometimes there might be some whether these people were more familiar with these documents or not might be just to the fact that perhaps having stayed longer in the US made them more familiar with these documents. That's just an assumption. We do not have that data. But in general, we can see that there are significant differences and disparities that exist in the knowledge of this advanced care planning document, that there is a lower percentage of people who identify as Hispanic in this clinic, who knew about these documents, and that so we need to really start from a place of, as far as thinking of interventions, really starting from education and making sure that the knowledge is there for all the community. And then that's an important part of ensuring this important part of Parkinson's disease care in all communities.
Yeah, no, thank you so much, Paulina. An interesting study, and I'd love to hear if any of our expert discussants have other comments or questions about this. Sana, please go ahead.
Yeah, I think we go back and forth about the importance of generalizability, but then also recognizing that we must know our own community where we work and creating culturally, culturally adapting, whether education if it's patients centered or just kind of taking the local context in mind. And so, I wonder, and just thinking out loud, if the focus from generalizability needs to shift a little bit into what are we actually, is the method the more important thing that we extract from these studies rather than the actual endpoint, in that there are cultural differences and that we just need to adapt education to our local community more than anything else.
No, it's a great point. And I did, when I read this article, and thanks so much for walking us through it, Paulina, I've learned a lot from all of you today. Yes, the limitations seem to be it's single center, it's mostly Cuban American, but I'll tell you, as a stroke person, in my experience, this sentiment, this philosophy aligns very much with what I see in many minoritized populations in terms of the way they are reluctant to talk about these things or are not aware of them. I was especially struck by not just the fact that the Hispanics in this population were less likely to report having heard of ACP documents, but also that they prefer to discuss it later in the course as well. So that was another nuance there that was very interesting. I don't know, Paulina, what your thoughts about that are.
Yeah, certainly. I mean, I think as someone who identifies as Mexican, who's of Hispanic descent, I was not as surprised about this finding in the sense that I think it made sense from what I know of Mexican culture, but also as a practitioner, I wish this is one view that I would wish to inform more and try to sway the opinion about, because as a physician, we know how important having these conversations earlier actually are, not just for the person with the disease, in this case with Parkinson's disease, but also for their family members. So I think this brings me to another thought about this survey, is whether that it would be interesting to know whether we see any differences between the opinion of the answer from someone who's the patient, who is the person with Parkinson's disease, and their family members. Perhaps the family members I found are sometimes the ones who want to initiate this conversation, especially if there's younger family members who are part of the caregiving team. Yeah.
Other thoughts?
Yeah, it's so interesting, Bruce and Paulina, both that you sort of mentioned some of the similarities across different minoritized groups. I can just see my mother coming back from an initial appointment being very upset that death was being discussed already, or
right.
whereas, anecdotally, other groups very much just want to talk about the whole, what does the endpoint look like, which is, so yeah, the cultural aspect is very interesting.
But I think it
Go
also
ahead.
has to become like a part of regular conversation. You kind of have to normalize it so they don't see it as like extraordinary. Death is natural. We're all gonna die. And like when I talk to people, I tell them there's no guarantee I'm not gonna get hit by a bus when I walk out of here. So I may go away before you. And, as the person that's seeing me last, I would want you to know what my preferences are because it is such a big burden on their loved ones. Because, when you're dealing with your loved one's loss of independency, quality of life, you have to make certain decisions for them. And you're trying to make sure that it would align with what they would have wanted. But it's tough to make that decision, and you kind of want to know what they would have wanted before they got to that stage. So, it's not just for the person, but also for their loved ones too.
Can we please delay the fact that everybody's going to die to the end of this presentation?
I was just going to say, perhaps the future Disparities dialogue will be about palliative care just in all of neurodegenerative disease, or just
That's right.
neurology,
That's right.
rather than just Parkinson's.
Right. Great discussion. Thanks, Paulina. That was terrific. We'll move to our next article. I beg your pardon. We are a little bit over. So we'll move to our next article, which is to talk about the issue of disparities in access to deep brain stimulator for Parkinson's disease. It was a paper published in Movement Disorders Clinical Practice 2025, and Dr. Lizarraga is kindly going to walk us through this. Karlo?
Yeah, thank you. Yeah, this is a study done in Canada. And I'm glad that I'm last because I'll be using a lot of what we have discussed so far. So I think across the world, we know that there are disparities in the access to DBS for people with Parkinson's disease, and it's very interesting to see the perspective from our Canadian colleagues. So main difference in the Canadian health system compared to the US is that they have a publicly funded system that mandates that everybody should have access to equally to every treatment. And so based on that, our Canadian colleagues, they expected, some findings. So they did a retrospective review and they complemented that with a phone survey. They used 5 heterogeneous groups from 2 DBS centers, looking at both their referred patients and those that ended up being implanted. And they added data from our registry. And they looked into, demographic, clinical relevant variables. I found it very interesting how they didn't really talk about race, for example. They talked about ethnicity. And that goes along with one of our earlier discussions about how other countries don't mandate or don't even understand what race is. And so, for example, they didn't define race. They defined ethnic categories based on Statistics Canada. And they did apply, I found it also very interesting that it applied a Bonferroni correction, which is something that wasn't done in other similar studies. So in the end, they had reasonable numbers. So you can look at the numbers there, 73 referred patients and 20 implanted for one center. Another center contributed with 101 referred patients and 88 that ended up being implanted. And from the registry, they obtained 43 more, or data from 43 more patients. This was over a decade. So the first finding that was interesting is that the ratio between men and women that were referred versus the ratio of men and women that ended up being implanted. So you can see there that the ratio was 1.7 when they were referred, and that increased to 2.3 after implantation. So that means that about 35%, there was a 35% disparity between referral and implantation, and that was statistically significant. Another finding was that this was also a limitation, that was that around 90% of the patients were white, and this is overrepresentation because in Canada, 68%, 0.5% are white. This was also statistically significant. Now, what's interesting is they found that people who ended up being referred and implanted, they both have had higher education level compared to the general population, and this was statistically significant. They also found that people were more likely to be married, both in the referral and the implanted groups, also a significant finding. Another one was that people who were referred by subspecialists, specifically by a movement disorder specialist, was much more likely to end up being implanted, as opposed to patients referred from community neurologists. I thought this was really interesting. It could also apply to our own practices. They didn't find differences in income or rural versus urban residents. Again, I think some of the you could think some of the methods were limited, but that also adds some strength to this study. So I think the main conclusion was that there was overrepresentation of educated white men that were married, as they were much more likely to end up being implanted, first referred and then implanted, especially if they were referred by a subspecialist in movement disorders. The authors concluded also that confidence and support are essential in the decision-making between referral and implantation. And this led to this interesting discussion about affinity bias, because most movement disorders neurologists, most neurologists, tend to be white men, and there's that affinity with white men who are referred and end up being implanted. This is really complex, hard to study, especially quantitatively. They pointed out that diverse teams may not be sufficient, because the center that had more data for this study, they pointed out that they had a very diverse team, both in sex and ethnicity. But even with that and their own deliberate efforts, they also had the same pattern. And so they conclude that this inequalities may be shaped by societal context. Yeah.
An interesting study, Karlo. Thank you so much for walking us through it. A lot to unpack here. And the issue of affinity bias could be, but I wonder if there are other reasons or factors contributing here potentially. Thoughts, anyone?
This is so interesting, because I think oftentimes, we come up with, like, if everyone had access to healthcare, if that were not the rate limiting step, that would make it equitable. And clearly, it helps in some things, right? So, rurality was not an issue. Household income was not an issue, which is an issue with advanced therapies in the US, at least in US databases, but not for other groups. And so, it's interesting, because there's clearly more to it. I know there's been work in like men versus women and risk aversion for surgical interventions, and so again, where is that roadblock? But it's disappointing data in some sense that one hopes that this would be different in a certain context. But I think it's also very helpful in really kind of honing in on, like, well, where is the problem, or the solution is not just healthcare access for everyone. It needs to go beyond that. And I think Canada has its own heritage of mistrust within the healthcare system amongst minoritized groups.
Thank you, Sana. Other thoughts, if any?
Yeah, there's I want to bring up much more recent systematic review, also published in Movement Disorders Clinical Practice, and it was specifically about disparities in access to DBS, and they brought up a point that we don't think about too much, and it's our own bias. Our own bias is when interpreting the data,
Mm.
and like when you read this paper, I mean, of course they are Canadian, they have the cultural background necessary to interpret data, but they don't. We're not collecting the data we would need to interpret these findings. And again, this new paper that I mentioned, they call it cultural conjectures, something like that. So like our own interpretation of the data is might be biased as scientists, and I think we probably should be asking patients a little bit more about what the reasons might be, but that will take a lot of work.
No, that's a great point. That's a great point. And Karlo, if I may, just as a lowly stroke neurologist, are there any ethnic specific effects of DBS on the symptoms of Parkinson's disease?
Yeah, so thank you, Bruce. So this is kind of a very important question for all of us. So do we actually understand if ethnicity, race, gender, sex, or any of this social construct, if they actually have biological importance? For example, in terms of ethnicity specifically, there's no data to support any claim. And actually, I think that's a little bit of a dangerous route. There is a book called Fatal Invention that I would strongly recommend everybody to read. And I hope we have learned like from other fields in medicine how, if we try to explain medical or biological findings based on race, that may lead to dangerous paths, right? Like the renal function equation with separate values and other examples. But we don't have it. I mean, neurology, DBS, I don't think we have any data to support any of that. There is some, anecdotal data, but nothing really well studied. In gender specifically, I think there is a little bit more data. We know for some reason women are more likely to have worse dyskinesia than men, even correcting for the dose of levodopa and other variables. We don't know why. They tend to have a little bit more pain, more depression also before surgery. And after surgery, they also tend to have better cognitive outcomes compared to men. But again, these are all like not rigorous enough to, make firm conclusions.
I see. Other thoughts?
I mean, I think some of it also kind of comes back to just how few people are getting DBS and then how very little diversity there is in that population. And so, I mean, it's hard to even study these questions. It's not that no one's asking, just people are not getting implanted. And so we have such limited data for that.
I see. So for one, be very careful about extrapolating because there isn't any clear evidence. And number two, there might not be clear evidence because we don't have enough data to begin with. I see. Okay, got it. All right, that's helpful. Thank you, thank you. Let's move on to our last paper. And so this looks at the issue of gender differences in depression, anxiety, and quality of life in Parkinson's disease before and after deep brain stimulation. Was published in BMJ Neurology Open. Dr. Lizarraga, help us with this one, please.
Yeah, so this is a good follow-up. In this study from the UK, they try to go a little deeper in understanding gender-specific patterns before DBS, and if those patterns exist, if there was any difference in the response to those symptoms to DBS. So they took data from 7 DBS centers in the UK. They used self-reported scales for depression, anxiety, quality of life before DBS compared to 6 months after bilateral subthalamic DBS. So in the end, they ended up with 61 data from 61 participants. You can see there only 17 were female, so that's 28% versus 72% for males. They found that before DBS, depression and anxiety were similar between female and male participants. Quality of life was worse though in females, and they found that all the sub-items of the PDQ-39 had lower scores in females, including mobility, support, pain, career engagement. Interestingly and very importantly, they didn't find any difference in the dose of levodopa. Now, 6 months after DBS, they found that anxiety scores improved in both groups, but female scores remained worse. Moderate depression improved more in males compared to females, and quality of life improved similarly, but it remained worse in female participants. They also tried to find predictive variables, and they found that after that post-DBS depression can be predicted by longer duration of the disease, worse quality of life, and worse mobility. And also interestingly, anxiety after DBS was predicted by female gender and reduced support. As a limitation, this cohort study only included patients implanted with subthalamic stimulation, not with any of the other targets. The sample size, especially for female participants, was small. 97% of participants were wet British. Another limitation is specifically for the GAD-7 scale that hasn't really been validated in Parkinson's disease, although it's used in other areas such as epilepsy. Of course, for any reported scale, you can have reporting bias that can limit your findings. So in conclusion, I found this very informative actually for my own practice as a DBS specialist. So there were specific barriers in females, including increased anxiety, reduced support, and less care engagement before DBS. And in terms of like the non-motor improvement after DBS, it was similar in both genders, but the improvement was greater in males. And so this is important as we probably should be tailoring our pre-surgical evaluation counseling to based on these findings. And this is also very important for research because, for example, the NIH considers sex as a biological variable as a very important part of any proposal. And so we don't really understand the biopsychosocial underpinnings of gender-based differences, as I've mentioned before. But these findings should inform our practice, especially when, evaluating a female patient.
That's fascinating, Karlo, because I learned a lot from that. And on one hand, I'm thinking very impressive, but then you also taught me that there are several limitations to it. So I'm wondering how much it should inform our practice, given all the limitations you mentioned. But what do others think about it?
I think tailored counseling is really like the most important thing. It's not that, hey, we shouldn't do DBS because, they're more likely to experience these problems, but it's that we should be aware of what may be coming and offer proper support so they can navigate that process better. I really think like this is the take-home message for any of the disparities findings. It's not that this group of people shouldn't be doing this, or this group of people, we should always think about these problems, etc. It's that you have to look at it individually. If they're, female who identifies as a woman from Hispanic backgrounds, then perhaps we may be thinking of these, but we don't have to stick those like this is 100% guaranteed kind of a thing. Tailor it with the person, including the person in that process as well.
That's very well said. And Karlo is going to walk us through a paper that he led, a fantastic paper, which is really a seminal work along with other key leaders as to how we can potentially better integrate equity into translational research in neurology. So Karlo, teach us.
Yeah, thank you, Bruce. So I'm not sure it's seminal work, but I was struggling, when I came to the US from Peru and Canada, and I just had to learn how to deal with what was going on in the society, right? Like with the race and ethnicity and all these differences. So my mentors just suggested, why don't we put together a conference, and it ended up being a conference well attended with leaders in the field, as you said. And we put together these kind of strategies to try to address the problem. So in my own experience, like the first thing I had to do was learn history, and particularly the history in the US, and where do these differences come from, and why are they still so important and pervasive in our practice. So that was the first strategy. Then kind of learning about upstream forces that kind of shape our cultural and societal assumptions. As I mentioned before, and this has been actually well recognized more recently, we as scientists, even though we try to be objective, can also be biased by our own upbringings, and that should be kept in mind. Then, the third one was to include as many people from different backgrounds and perspectives as we can, but not just to check the box that we are including people, but to actually make them participate and lead these efforts. And the word liberate there was because we felt that yes, we maybe are in a better position to start these efforts, but the goal should be in the end to kind of have them lead their own community-driven efforts in what they think it's important to them. The fourth one was about language, very straightforward, but sometimes we forget. Communication is really important, how we talk to each other and our trainees and our patients. Social drivers of health, lived experiences is something that we probably should be including in as research variables with every clinical research that we are trying to undertake. The sixth one was kind of leveraging health technologies as they, become much more widespread and much more accessible to populations worldwide. Just being mindful that sometimes that can exacerbate existing inequities, and so we have to be careful. And the final was to about culturally humble teams, how we should deliberately try to do that. So thank you, Bruce.
No, thank you. And again, I think it's a wonderful article, and I've cited it several times in my work so far. And so thank you for going over it with us. So with that, we'll say a big thank you to our experts today, Dr. Aslam, Dr. Bayram, but Dr. Latapi and Dr. Lizarraga. These are all very busy clinicians and researchers, and so really grateful for taking the time and the trouble to lend your wonderful expertise. We hope that you'll come back again to discuss more movement disorders articles in the future on Disparities Dialogue. I also want to just speak to our audience to remind you that Disparities Dialogue is part of the Society for Equity Neuroscience. We have our upcoming conference on May the 14th, 2026 in Charleston, South Carolina. It's a hybrid conference, so please join us. We also have our journal, Equity Neuroscience, of which Karlo is an associate editor, and please submit your work to us or feel free to become a reviewer for us. And then finally, we have our No Brain Behind podcast, which is highly subscribed, thankfully, but we invite more and more of you to participate and suggest guests for future episodes. Thank you all very much for your kind audience.